Good day. My name is Martin Pollizotto, and I am a BSN to DNP adult geriatric acute care nurse practitioner student at UT Health School of Nursing. Today I'm going to talk about ethical considerations when placing advanced therapies in the ICU, such as mechanical support devices, ventilators, and continuous renal replacement therapies with respect to patients' rights to dignity and quality of life when in disagreement with the patient's family requests. It is 2 a.m. in the ICU. Your sickest patient is a 79-year-old male MI that was transferred from an outside hospital for a higher level of care earlier in the day. The patient was found in cardiac arrest, at least 10 minutes of downtime without CPR. ROSC was achieved by EMS. However, the patient now has a GCS of 5 and is in multi-organ failure. CRRT was started earlier in the day and a feeding tube was placed. He is intubated and sedated, paralyzed due to overbreathing of the vent. He is now on two pressors and is in cardiogenic shock with an EF of 10%. The family wants you to do everything you can for their grandfather. They read something about a treatment called ECMO that can prolong life. You know there is little to no chance of recovery nor quality of life for this patient. However, you are considering placing VA ECMO anyway per the family's request. They are adamant that we continue to do everything including CPR if needed and begin to become agitated as you continue to suggest there is little chance of recovery or even regaining consciousness. This is a scenario that plays out in ICUs every day. How would you handle this situation? As Professor Snape once said, we can even put a stopper in death. We now have the capability to prolong life to allow the body the time it needs to heal from whatever insults it has suffered. However, just being able to prolong life is not always the best answer. In many instances, the body may never be able to recover no matter how long we preserve life. We need to consider more aspects of the patient than just keeping the body alive. We need to consider what kinds of quality of life the patient will have if they recover and what that recovery may even look like. And if there is no chance of recovery, are we just stealing their right to die with dignity? Often we overlook these aspects of end-of-life care in favor of avoiding conflict with the family and avoiding litigation threatened by family because of unwillingness to allow their loved ones to die with dignity. It is estimated that as much as 40% of patients that die in the ICU experience suffering and pain during the last week of life. We know this, yet we continue to incorporate advanced therapies without an exit strategy. Why is it? Many new ICU practitioners have a mindset of save everyone, despite the futility that such a statement carries with it, without considering quality of life and patient dignity. Many new practitioners are also inexperienced and unaware of where the line sits between recovery and futility. Many more practitioners fear litigation from patient's family or are attempting to avoid conflict with the family, resulting in giving in and implementing an advanced therapy despite no evidence of any benefit to the patient, which is also the definition of futility often misused in the medical community. So I've thrown around a lot of terms here. What does quality of life, recovery, futility, and dying with dignity mean to us as providers compared to the patients we treat? How do we maintain patient quality of life and dignity, and how do we mitigate conflict with family before we reach the point of futility and or litigation? The World Health Organization defines quality of life as an individual's perception of their position in life in the context of culture and value systems in which they live and in relation to their goals, expectations, standards, and concerns. Recovery, as seen by the patient, is being able to resume life with the same quality of life as achieved before their illness. Futility is a concept often employed by practitioners to justify a decision not to pursue certain treatments that may be requested or demanded by patients or their surrogates. In fact, we should be using the term potentially inappropriate for many of these instances when discussing a care plan with the patient and or family or surrogate. Dying with dignity is a little more difficult to understand. Dignity is an internal value held by the patients themselves and is different for each person and can have strong affiliations with worth and self-esteem. Properly gauging the dignity of your patient can be difficult in the critical care setting, especially if they no longer possess capacity. Family is the next best source of information on the patient and can be discovered through open-ended questions such as tell me about your family or tell us what is important to them. Once we have an idea what values a patient possesses, we can begin to focus on providing the ABCDs of dignity-conserving care. This helpful mnemonic reminds practitioners about the importance of caring for as well as caring about their patients. The ABCD mnemonic stands for attitude, behavior, compassion, and dialogue. Attitude is there to remind practitioners to first and foremost examine their own attitudes and assumptions towards the patient. Once we know our own attitude, we can modify our behavior, the second step in the ABCDs. Healthcare providers' behavior towards patients must always be predicated on kindness and respect. Small acts of kindness can personalize care and often take little time to perform and have a lasting meaning. C for compassion requires a discourse about the healthcare provider's feelings. Compassion refers to deep awareness of the suffering of another coupled with the wish to relieve it. Compassion speaks to feelings that are evoked by contact with the patient and how those feelings shape our approach to the patient's care. And finally, D for dialogue. Maybe the most important of the four steps in dignity conserving care, you must be prepared not only to try and understand your patient, but also communicate with them and their surrogates, acknowledging the pain and suffering they are experiencing in this situation, listening to them intently, and provide accurate information about the patient, their care, and prognosis as possible to help them understand the situation fully. A simple dialogue should be started as soon as the patient is present under our care and continue regularly throughout their stay. Communication is where we all fail as practitioners. Family surrogate conflict is often the result of poor communication, resulting in demands or requests for potentially inappropriate treatments. Often these requests are for a cry to help, a desire to be heard or valued. Practitioners that use scripted guidelines when communicating with family and surrogates often resulted in a better understanding by the surrogates and less conflict regarding patient treatment options. A simple ethics framework that can be used to facilitate this is called a four-box method of communication. The four boxes pertain to medical indications, patient preferences, quality of life, and contextual features. Through these methods, preparing our communication with the family surrogates allows for a more thorough and complete communication, providing a better understanding of the patient's condition and prognosis. Understanding leads to less conflict and less influence and pressure to apply potentially inappropriate treatments that will only prove to rob the patient of their dignity in their final days of life. The focus of our care should not be only to cure and save lives, but recognize when healing the body is no longer the best course of action or even possible for our patients. The point where we no longer provide compassionate and meaningful care to our patient and are only treating per the surrogate's demands is the point when we have crossed the line and have gone too far.